Resources Committee. It is our July meeting, July 12th, and we have a couple updates here with us today. So it looks like I'm missing the front page of my agenda here. Oh, I got it. Never mind. Right here. So our first item on the agenda is public comment. Is there anyone from the public who would like to comment this morning? All right, seeing none. Our next item is approval of the minutes. Is there a motion to approve the minutes? Is there support?
Support.
Motion and supported. Any questions or comments on the minutes? All right, seeing none. All those in favor, please say aye.
Aye.
All those opposed, please say nay. Motion passes. Next item is a legislative update from Steve Carey, and he is joining us virtually. Welcome, Steve.
Good morning, everybody. It's good to see you. And I'm joined by my colleague, Charlie DeWitt. And if we could go ahead and start that PowerPoint, please. Thanks, Lisa. Here we go. Okay, are you moving it or is Charlie?
I will be moving.
Very good. You can go ahead and start with that the next slide when you're situated. There we go. Well, I'm going to just go ahead and kick it off with what the kind of the lay of the land right now. As everybody probably knows, Congress was out of session the past 2 weeks, the House and Senate. They're on better track to pass the appropriations bills than they were last year for a variety of reasons. I think that the election cycle has induced them to keep on better track. So the House has moved on the majority of their bills, the committee has. They're bringing them to the floor before the end of July and break for August recess. And that includes transportation, housing, urban development, energy and water, etc. The Senate is taking a little bit longer. It usually does, but in this case, the chairman of the Senate Appropriations, Patrick Leahy, had hip surgery that kept him away. However, the staff continued to press, and so they're going to do the best they can in July. The issue, though, everyone, is that they're gone for most of August, and they get in later in September than they usually do, again, because of the election cycle. And it's everybody's plan to leave early October. And as you know, the fiscal year begins October 1. So that's going to really press these lawmakers to push through these bills. I think you all see that this spells that it's going to be a continuing resolution probably after the November elections. I may be wrong. There's not been a real good template for how this process works ever since, I'd say, the past 6, 8, 10 years. It's been completely inconsistent. But I'm giving you the lay of the land so you are able to prepare for that threat of a shutdown. I don't think there will be a shutdown. But I need to at least prepare you for that, which is why I bring it up. Next slide, please. American Rescue Plan Act update. I'm going to turn that over to Charlie. So Charlie, if you could, please.
Yeah, we just wanted to give you an update on what has happened since the American Rescue Plan was passed in March of last year. And of course, that include about 1.5 trillion in county related funding. We're looking at that. We just wanted to note that Treasury came out with its final rule, and it's been implemented since April 1st. So that is an important milestone in implementation of ARPA. There is some flexibility in Treasury's final rules, including allowing counties to use up to 10 million of recovery funds as lost revenue for providing general government services. There's some other things in there. We'd be glad to offer you a little more updates after the call if you're interested. But we wanted to give you that update on what is happening with ARPA as it is being implemented, as well as all the other things that have been happening in this Congress.
Very good. Next slide, please. This is just a summary of what is contained in that infrastructure law last year. I believe you saw this before, but we're putting it in front of you just in case as a reminder. And as Charlie said, if you have any questions about any of the numbers, about whether it's transportation, HUD, energy and water, you name it, please let us know through Lori, and then we'll respond to Lori. So that's there for your edification. And I'm sure that this PowerPoint will be made available to you after we are concluded. Next slide, please. Back to you, Charlie.
Thanks, Steve. The status of the bipartisan infrastructure law, also known as the Infrastructure Investment and Jobs Act, is still ongoing. We provided you a little bit of background on the timeline. There is a timeline because there are so many different funding opportunities that are coming out from the Department of Transportation, the Highway Administration, the FAA, Transit, Energy, U.S. Army Corps, Minority Business Development Agency, and so on. The most recent announcement came a few weeks ago from the Highway Administration, and there's a major funding notice for the Bridge Investment Program. The Federal Railroad Administration also announced a funding program for some of its projects. So we want to keep you guys updated on that. We also want to say that it was back in April that President Biden toured the country with his bipartisan infrastructure law playbook in many counties across the United States. So again, if there are any questions about how this is being implemented, what is the latest on the status of the bipartisan infrastructure law, please let us know and be glad to follow up after the call.
All right, next slide, please. Charlie, back to you.
Yeah, we just wanted to also keep you informed. We've been updating folks on the Build Back Better reconciliation bill. This was sort of the original plan of the White House, was to have the Jobs Act and the Families Act, and this would be less of the physical infrastructure component of that. This was part of the plan to have have more of a soft infrastructure plan that would include social and climate provisions, as well as a lot of education and health provisions. The House passed a $2 trillion Build Back Better bill last year, but it was stalled in the Senate due to the opposition from Senators Manchin and Sinema, as many of you know. Ever since then, Senate Democrats have tried to revive some of the core elements of this agenda, and it looks like they are trying to push for another reconciliation package that is currently being negotiated in the Senate. They have already provided some background and text of legislation to the Senate parliamentarian to see if it can get approved under the complex rules that allow provisions under a reconciliation bill. And these are budget appropriations and spending bills that need a 50-vote majority or 51-vote majority in order to pass the Senate. And that's where we are right now. It looks like it's going to be a much more scaled back version this month, and it should come out by the end of the month. It may include some Medicare drug pricing, childcare provisions, maybe a provision to extend permanently the subsidies under the Affordable Care Act, but it doesn't look like they're going to include everything that they wanted as far as climate change provisions and major tax increases. So that's still up in the air. We just want to provide you with a basic background on that because things are changing every day. And this month is really the last opportunity that the Senate will have to pass a package. So we wanted to give you a little bit more on that, as well as everything else that's happening.
Yeah, and let me make sure that everybody understands what we're talking about. When we first talked about the appropriations schedule, what I started out with, that's annual spending. That's the 12 appropriations bills that keep the function of government moving. Again, paving roads, health research, Department of Defense, et cetera. What we're talking about is this kind of authorization bill to address these larger issues that they can't deal with every single year. So it's more of a broad brush that is imposed then on the federal government that does have implications on spending later on. And I know that some of you had raised the concern about the bigger package. That's what this is. It's that bigger package about which you were concerned on the price tag. This is, as Charlie said, a much scaled back version that is going to be more paid for, and it will be less on the social issues, climate change and so forth, and more on healthcare, et cetera. So just wanted to make that to distinguish the two kind of concepts there. Next slide, please. Okay, ARPA flexibility bill. Charlie, you can weigh in on this as well if you'd like, but this is a bill that we raised with you before. It's the Disaster Relief Flexibility Act. There's 157 co-sponsors, including Congressman Meyer, Molinar, Kildee, McLean, and Stevens. It's a bipartisan effort. It would provide state and local governments the flexibility to invest the ARPA funds in a way that had not originally been intended. And to Congress's credit, they realized and they heard from you and your colleagues across the country that the rigidity in which the funds were originally placed weren't flexible enough or practical enough for people on the front lines like you or city officials, et cetera. Charlie, did I miss anything?
Yeah, I think as it says here, it would allow counties, and this is very important, to use the greater of 10 million or 30% of their recovery fund allocation for things like CDBG, surface transportation, buses, highway safety, bridge replacement, and so much more. This is something where a lot of the major local government groups, including the counties, the cities, the mayors, the state legislatures, all wrote to Congress and asked them to include it in the FY22 omnibus bill, which passed in March 15th. Unfortunately, it was not included in that omnibus bill, but they still strongly urge passage of this. So there may be a way of passing this in some kind of end of the year package or something to that effect. We're in touch with the House bill sponsors to see where they are, what kind of status they can provide on where they are as far as the passage of this legislation. So we'll keep you informed of that. And again, if you have any questions, please let us know on how this funding can be used.
Thank you. Next slide, please. Are we okay with time, everybody, or are we over our allotment? Because I know you've got a lot to cover.
I think we're okay with time, and I think we have time if there's a few questions. Did you have anything else that you wanted to add, Steve?
Well, just to end on an interesting note, I would like to let you know that if you weren't informed yet, that Senator Stabenow included $7 million in the appropriations process for the Grand River Greenway non-motorized trail. And that is separate from what the state has actually provided this trail. I will say, though, that what the state provided was what you actually asked us to include in the bigger picture for the recovery funding overall from the past Congress. And as you all know, that funding went to the states, and then the states then allocated that funding. And so that's I think that was 30 million, Lori, maybe you can tell me otherwise, but this is actually $7 million through the annual appropriations process. And I think it's a credit to your advocacy. It's a credit to the West Michigan area and specifically Kent County for your vision. And we just need to make sure that the committee accepts it, number one. And given that Senator Stabenow is part of leadership, we're pretty optimistic. And two, that Congress actually ends up doing its job and passing these appropriations bills. As everyone may recall, the previous appropriations process was finalized in March. And if this goes into next year, into next March, I believe this could be stripped along with every designated project. So wanted to give you the good news, but a little bit of caution. So with that, we're happy to answer any questions.
All right, thank you. Do I have some questions here? Commissioner Coleman.
Thank you, Chair. Steve or Charlie, I'm just wondering what the impact might be as the Fed raises interest rates, what budgetary impact there'd be from that on the federal debt?
If I heard correctly, the increase in the interest rate and the federal debt, that has not been calculated yet. I know the White House, and specifically that falls on the plate of a gentleman named Jared Bernstein. He is still crunching those numbers. But whatever the impact will be short term, it would be their goal for medium and longer term to actually control the overall budget increases as a result of an increase in the interest rate, just because of the inflation. I think, if I could, your next question might be, well, maybe all of this infusion of federal funding had something to do with that. I can't disagree with you. I'm not an economist, but that has been the issue, which is why Senator Manchin did not want to pass the Build Back Better bill as it stood. So what I think we've seen is, with COVID, there was an alarming lack of resources through the federal level, obviously, and then all the way to the local level. And so there was a push to get that funding back in everybody's hands. And it wasn't calibrated perfectly because, again, there's no template for COVID. But we're feeling the effects. So I think that people are just monitoring and tweaking to the best of their ability. I hope that was your second question. Otherwise, I just spent 45 seconds unnecessarily.
It's all right. I think it was. Matt thinks ahead
Good,
like that.
Thanks.
Any other questions for Steve or Charlie? I have just a statement or a comment. Yesterday at the airport, can you hear me okay, Steve?
I can hear you. I'm being the old guy here, leaning in a bit.
Okay, so we had our Department of Transportation Secretary Buttigieg at the airport, the Ford Airport, and he announced some funding, $8.6 million, that'll be going towards improvements in jet bridges at the airport with the new Concourse edition. And I think he had maybe a half dozen or so people mention the air traffic control tower to him. So he's very aware of that and the need for moving that and replacing it. And he could see it. We were right on the runway there, and so it was pretty obvious. So if we can keep continuing our joint effort of encouraging the FAA and the Department of Transportation to send some funding our way and also other resources, that would be helpful. So
thank you for raising that. I did have a long discussion with the administrator, and I know that they also have an advocacy organization here in town, and we exchanged a few emails, but that's about where it ended. I need to regroup with them, and I know that you had tasked me with working with them, and I give you my word, I will do that. And perhaps with both organizations, we can get to that point where we need to at the airport. It is a unique situation where the FAA actually owns that air traffic control tower, so it's not just an easy fix. It is peculiar, it's a challenge, but if it were easy, we'd be there by now. I hear you, and I will make it a point to regroup with the administrator.
all right, thank you. Any other questions at all? All right, I appreciate your time and the update and always keeping us informed. Thank you so much.
Great to work for you. Thank you so much, everybody. Call
Thanks.
if you have questions.
All right.
Thank you.
All right, so our next item on the agenda is another update, a legislative update from Becky Beckler. Thanks for joining us today, Becky. We'll let Lisa close down the Zoom.
Everyone. Well, like Congress, the Michigan legislature has also left Lansing for the better part of the summer. It's likely that they will not return until after Labor Day because of the election, similar to what Steve indicated on the federal level. However, the good news is that Michigan legislators left town after completing the 22-23 budget. They had self-imposed a July 1st deadline. There's no penalty if they don't reach that, and as you know, last year they did not submit a budget by July 1st, but this year they were able to accomplish that. It did take quite a while. They started at 10 o'clock on Thursday morning and didn't vote on a bill until about 3:30 in the morning on Friday, July 1st. But it is completed and hopefully on the way to the governor. It has not been presented to her as of yet, but we are closely watching when she will actually receive that and have the ability to sign it. We don't know if there's an agreement as far as what she would, if there's vetoes included. She seemed to make reference to that earlier this week, but we were under the impression that this was a budget that was a consensus budget, that everything had been agreed to, but perhaps there's some boilerplate or some other items that were not, and we'll keep you apprised. It is an aggressive budget, about $76 billion in spending. The agreement includes $19 billion in school aid fund and $15 billion in general fund. What was not included is any type of tax relief. That's something that the legislature really wanted to be included. So that is still left on the table, but there's also over $7 billion unspent. So there's room for that conversation. It's our understanding that the legislature and executive office agreed to set aside $2 billion of that for when they come back later this year, they could perhaps reach an agreement. From the executive perspective, their priorities are around expanding the earned income tax credit, repealing the pension tax. Those are two items that she referenced in her State of the State in January, as well as offering a $500 rebate to taxpayers. From the legislative perspective, and specifically the Republicans, they would like to lower the income tax rate, offer a child tax credit, or pause the fuel tax. And those are all items that on some level they have sent that to the governor. However, she has vetoed those. She was not supportive of the way in which they were submitted to her. So there's a lot of room for conversation, probably most likely this fall in September and October. There are several items in the budget that I just wanted to review with you. Most of these are at a high level, but there's a few county specific that I wanted to bring to your attention. The education budget is $19 billion. It's one of the largest school aid budget in history, by over 15%. It increases the per pupil funding by $450. There's also $25 million for the Michigan Future Education Fellowship Program. This is a grant program trying to offset tuition for those individuals that will go into education and stay in Michigan for 3 to 5 years. There's also funding provided, try to find a no-cost provision or pathway for those that are student support staff that want to go into teaching. Can we get them into teaching without causing any type of tuition debt for them as well? In the Health and Human Service budget, that is also in a very aggressive $33 billion budget that was put together and agreed to. Probably most important is that $5 million was dedicated to Network 180 for the Crisis Stabilization Unit in Kent County. Over $493 million has been set aside for program increases for dental reimbursement, primary care physician reimbursement, to raise those reimbursement levels, trying to get more dentists and primary care physicians to be willing to see more Medicaid patients. There's also over $444 million for behavioral health, additional facilities, additional care service programs statewide that the governor will support. There's also $10 million for a jail diversion program. Within the transportation budget, there is an $87 million increase in local road agencies, $33 million for county road commissions, cities and villages, and $27 million for local bridge programs. On revenue sharing, counties received a 6% revenue sharing increase. 5% of that is ongoing and 1% is just a one-time increase. Within the Eagle budget, there's $500,000 as a one-time general fund to provide help for the disposal of firefighting foam that contains PFAS. And I know that's something that's statewide, but I wanted to bring that to your attention. There's also $5 million for local public health departments to provide free or low-cost water testing to private well owners, and $7.5 million to local public health departments to monitor and test local drinking water. Other items that have been funded that I thought would be of interest to you is $40 million for the Pure Michigan, $15 million for Going Pro, $414 million to maintain the direct care worker increase, $150 million for a statewide judicial case management system, $7 million, this is federal dollars that they pass through to help clear the trial court backlog, as well as $4 million for Raise the Age funding. The LEO budget is probably the most intriguing because that's where they have all of the enhancement grants. They actually put them into 4 categories. $200 million was Michigan enhancement grants, $331 million for special grants, $212 million in Michigan infrastructure grants, and $251 million for economic development workforce grants. There are 100 projects in the enhancement grants, 28 projects in the workforce development grants, and 17 projects in the infrastructure grants. Some of those that are county-specific is $30 million was dedicated to the Grand Rapids Amphitheater and $11 million for the Grand Rapids Museum. $10 million for the Mary Free Bed Hospital for a new children's rehab hospital. They also put $100 million in the Budget Stabilization Fund, bringing that up to about $1.5 billion. And one point that I did miss is that within the state police is a $15 million secondary road patrol grant program. This is important because it offers a stable entryway for funding, and it's something that we've been working on for quite some time. So it's overall a good budget. I think there are many good things for counties. As I said, there's still $7 billion yet to be spent, so it could be a very busy fall before the November election as they seek to figure out ways in which to spend those dollars. I would be happy to answer any questions that anyone might have.
Are there any questions or comments, thoughts? Commissioner LeGrand.
There we go. Do you have any more detail on the jail, the $10 million for jail diversion, and what is intended for that, or how that's to be spent, or the extra money on mental health spending?
There's quite a bit of mental health funding. I'd be happy to get you the complete list. It is a statewide, it's pretty aggressive statewide plan that they have done, and it's through the enhancement grants as well as within the budget. So I'd be happy to pull all those out and provide that to you. The jail diversion program, something's been in previous budgets, but I will get the boilerplate around that as far as specifics to you as well.
Okay, thank you.
All right, any other questions? Do you have anything to add? No? All right. Thanks for joining us today, and keep us updated on that, $7 billion later this year that hopefully will be allocated in some way, shape, or form. But we appreciate all the efforts that you've put forward.
Yes, and thank you to the many commissioners and some of your leadership team, as well as some of the county statewide for helping make sure that these projects were funded. This was a different budget process. I don't know if it'll continue, but literally this budget was negotiated by 3 individuals: the Senate Appropriations Chair, the House Appropriations Chair, and the Governor's Budget Director. So our champions within our county, as well as the subcommittee chairs, weren't part of that conversation, and so we needed all hands on deck, and so I want to thank everyone for their assistance. It wouldn't have been possible without that.
Thank you. All right, so our next item on the agenda comes from the Health Department. It's clinical and community wellness, and it's performance measurement reviews. Thanks for joining us today.
Good morning. Just a moment as we bring the slide deck up. And thank you for allowing us to break this year's presentation into 2 separate reports. In the past, we tried to pack a lot of health department programs into one 15-minute report. I don't think it was a lot happening in 15 minutes. So today, we're going to profile some of the measures in community clinics and community wellness. And I've got Joanne Hoganson with me, who is the Division Director in Community Wellness, who can provide some more detail to questions that you may have. And then next month, low-profile environmental health and some of the community collaborations that we're doing as well. So you know the general rundown of how these PM reports go. Can talk briefly about our alignment with your board priorities, some of our goals, the health department, some select metrics from the health department, some significant accomplishments, and then what we're looking forward to in the near-term future here. So you're well familiar with these, of course, as well, your 5 priorities. At the health department, we focus an awful lot on quality of life, and quantity of life is really important to us in that as well, and excellence in service delivery. Our mission of the department, I'm really proud of our mission statement. I think we have the shortest one of any department. Serve, protect, and promote a healthy community for all. And I really want our staff to understand that and to be able to repeat that. And if they can't do that, at least if they know that the 2 most important words are the first and the last words in that statement, which are to serve all. And that's really what drives us at the health department, is to serve everyone who's here. Everyone who lives here, everyone who's visiting here, everyone who's working here, and they're our mission. And today I'm going to focus again on community clinical services and community wellness, and a little bit on administration and some of the goals that we have therein. So the first metric is related to reportable diseases. And so you know there are about 80 approximately notifiable diseases that by state law, when a physician diagnoses someone with, whether it's pertussis or Ebola or E. coli or any one of a number of COVID, right now monkeypox, they have to notify us within 24 hours of that diagnosis. And then we can follow up with an investigation, which we're going to look to find out where they ate, who they've been with, where they swam, whatever the disease might be, to try to identify what the risk factors may be and who are those who may have been exposed, so that we can provide them with useful information to protect their health and the community's health. This particular measure is really one of those, I think, canaries in the coal mine of how the department's doing overall, because it's not just are we investigating that report within a certain number of time, but we're actually completing the follow-through of generating the report that the state wants. And the state holds us to this measure of 95% of those reports are completed within 30 days of notice. To be clear, we always follow through with contact with those who are infected or with their contacts within a shorter period of time. But within 30 days, we have to have that written report done for the state. Now you'll see we were there about 4 years ago. We had just reached that mark. For a number of years before 2018, we had struggled to hit that mark, and we actually added a position in that program to help us with that. We were near there in 2019, and this was with us doing a few thousand investigation reports every year. Of course, in 2020, that went up to about 42,000 as COVID really hit us hard. And then last year, we had, I believe, about 86,000 investigation reports that we had to complete. And so while we didn't meet our 95% goal, I think overall we're much more robust there, and the raw number, the raw challenge of providing this many reports in that amount of time was really a huge burden. But I do have a lot of confidence that going forward with COVID numbers dramatically coming down, that we'll be able to hit that 95% target. Next measure is the percentage of kids, the toddlers, the 19 to 35-month-olds that are fully immunized. And this is measles, mumps, rubella, diphtheria, pertussis, tetanus. Those that we want to get to 71% in those first 3 years of age. Now, we continue to get higher than that as kids approach school. By the time kids are in preschool, our rate is in the high 80 percentile range, which is kind of really where we want it to be, there or higher going into school. You'll see that we are approaching that number in 2019. During the pandemic, we've come down about 4 percentage points. That's not a surprise to us, as well child visits were postponed or rescheduled. And became more challenging to get kids into the doctor's office. So that's one of our priorities going forward, is that we can get back to where we were and going upward again with our vaccine coverage rate for all those programs. Common theme here in what we're doing in community wellness and clinics has a lot to do with the moms and babies and health. And creating a Kent County that is warm and welcoming and a healthy place for moms and babies is a very high priority for us, the health department. This program here is the Maternal Infant Health Program. And it's one of a number of programs along with Nurse Family Partnership and Strong Beginnings that really focuses on the wellness, the health of pregnant moms, new moms, babies, and the family that lives with them and supports them as well. You can see that we had a decline from 2019 and 2000 with the number of client visits that we're doing in the maternal infant health program. Again, this had a lot to do with the pandemic and our limitations in getting into the homes of moms and babies. That number thankfully is coming back up, and it's a huge priority of ours to make sure that we get that level of participation there and going upward even more. We've heard an awful lot in the past few weeks about concern about the number of services that are available for moms and babies. And this is one of those great services that's available in our community that we can help to get those new families off to a great start. Our refugee resettlement program and our health screening program. We work closely with Bethany and with other resettlement agencies here locally to make sure that those who are coming here through the refugee resettlement program are off to a great start. These are people who are coming from places around the world that are really in battle with civil war, with other strife, places like Cuba, the Congo, Sudan, Burma, Syria, and elsewhere, that they've gone through the process through the State Department to come here the right way, and when they get here, they're very vulnerable. And so the health screening that we provide helps to make sure their mental, their dental, their TB status, they have what they need in early assessment, and then they're getting care navigation through partners and to other organizations who can provide that care directly to them. Now you'll see that we had a big drop off in 2020. Of course, again, you can imagine that's because of the pandemic, and you'd be correct. Generally, we're serving between 500 and 1,000 new refugees per year in that program. It's coming back up again. You'll see so far in 2022, we've had 354 refugees that we have helped to do health screenings for. The big increase so far this year is because of refugees from Afghanistan. And I think this is one of the programs that our community should really be proud of in the work that we're doing to bring these, to help these new members of our community get off to a great start. And I know that a lot of our families have been touched by everything that's happened in Afghanistan over the past 20 years. I know Al has a son who is a veteran from Afghanistan. My younger brother is a combat veteran from Afghanistan. And these are the people and the families of those who are helping. They're aiding and assisting our families when they were there serving our country and protecting theirs as well. And to be able to help them here is a great feeling for a lot of us. Okay, Children's Special Health Care Services. This is another program I think our community would be very proud to know that we're doing. This is a program where we provide counseling, coaching, care, and assistance to children and families that have chronic illness, injury, disabilities, and our staff provides those services to those families to make sure that they have assistance with learning how to take care of catheters and feeding tubes and ventilation tubes and all the things that are complicated for especially new parents when they have a baby that they are born or they adopt that has severe health complications, that we can provide great service for them and help them with that support, and also the social support with having that system of other families that can provide that help for them as well. You'll see that our numbers of enrollment have gone up quite a bit in that program. They've actually increased by over 54% since 2017. And that's largely due to the fact that the number of diagnoses has expanded for eligibility into this program. We also want to get the word out there that this program is there because we know that there are other families that could use this assistance as well. There are a number of other metrics that we could talk about. I just want to briefly go over a few here. We have Our tuberculosis program, people think of tuberculosis as something that was from the 1800s or something, but no, we still have tuberculosis. And it's still a significant threat if untreated. We identified 7 active cases of tuberculosis last year, and we thankfully were able to work with them to bring them fully to full treatment and to a full successful outcome. We also have a couple hundred people actually in that program who have latent cases of tuberculosis, and we work with them to make sure that they have treatment and surveillance of their condition so that it doesn't become active. We have about 13,000 participants in our WIC program. We also would like to make that more well-known and more accessed by the community who are eligible for those services, especially as our economy is under some stress and the cost of living has increased. We were able to increase the number of enrollees in our prophylaxis, our pre-exposure prophylaxis program for HIV by 153 last year. That's almost doubling the number of people in that program who are at high risk of HIV that hopefully can avoid that condition. We had an increase in the number of schools that are in our life skills program. This is a skills program for middle schoolers and for high school kids, all focused on substance abuse prevention, where we're sending health educators into the schools. Right now, 48 schools, 158 classrooms. And the evidence supports the value of that program, where 5 years after successful completion of that program, those kids have a lower rate of substance use than kids that aren't in that program. And last year, despite the challenges of the pandemic, we were able to screen over 85,000 kids for hearing and vision. Normally, we're at about 92,000, so we did see a challenge because schools were closed. I mean, we saw that kids weren't in school as much. But we still were able to screen 85,000 kids. And what we usually find is that about 3 to 5% of those kids, and these are kids at preschool, kindergarten, 2nd grade, 4th grade, 7th grade, and freshmen in high school, about 3 to 5% have a hearing deficiency. And about 8% every year have a sight deficiency. And so we're able to work with the schools and their parents to make sure they get navigation towards providers who can help them with those deficiencies. And our infant mortality rates continue to trend downward. And again, this goes back to the successes of some of those programs like MIHP, Nurse Family Partnership, Strong Beginnings, and others. I want to show you a table here, and I know there's a lot of data there, but just to show you a general trajectory of trends. These are 5-year moving averages going back to the late 90s. And there at the bottom of this table, you see those older years where that first column is the year range. The second column is for here in Kent County, the average number of infant deaths that we were seeing every year. So you look at those, say the last 6 or 7 values, and they're in the 70s. Every year we were seeing 75, 76, 79 infants die here in Kent County. And that's children below the age of 1. And in the fourth column, you see the infant death rate. And that number, like 7.6 there at the very bottom, is the number of infants under the age of 1 who die out of every 1,000 that are born. Okay, so you'll see that during those years, 20 years ago, we were averaging, again, 75 to 90 or to 80 infant deaths per year here in Kent County, and an average infant death rate right around 8 or the low 8s per 1,000 births. The last 5 or 6 years, we've been down around 50 infant deaths per year, and a death rate that's come down around 5, 5.9, 5.8. So we're seeing about 25 fewer infant deaths per year here in Kent County pretty consistently now than where we were at. And I think that attribution is really hard with things like this, but I think that there are a number of things that the county has done and that a lot of others in the community have done to make this, again, a warmer, more welcoming, safer place for moms and babies. We want to continue that work, and we want to, of course, make sure that that number gets down near 0 as close as possible, and that's one of our goals. So a few significant accomplishments from last year, and this is an image, of course, from our vaccine clinic at the Fuller site, when we had the mass vaccine site downstairs. Very proud of that. We had many thousand people come through that site, and that was a very accessible location for people to use. A lot of data on this slide, and I won't go through all of it, but I want to point to a few things. In the kind of the center left, we have the total number of doses and fully vaccinated individuals here in Kent County as of last week. And altogether, the county plus all the other providers of vaccine here in Kent County, the hospitals, the doctor's offices, the pharmacies, have administered over 832,000 doses of COVID vaccine. And we have about 414,000 people over the age of 5 who are fully vaccinated. And that's about 67.5% of that over 5 population is fully vaccinated. Going clockwise, you'll see the graph there that shows the doses administered by day. So early 2021, our significant accomplishment was moving that much vaccine that quickly. And of course, that was a huge reason for the DeVos Clinic, the West Michigan Vaccine Clinic at DeVos Place, in partnership with Spectrum and St. Mary's. And we were able to do it. We were able to move an awful lot of vaccine in the community in a relatively brief period of time. It was kind of the unique days where we literally had people at our door every morning and every night wanting to get vaccine. There was that level of desire to have it as quickly as possible. And then, things tapered off quite a bit with that. And over the course of the last summer, the pace slowed down, kind of that middle third of people that, they were willing to get vaccinated, but they wanted to kind of see what experience others had first. And we've largely gotten that group now. You see a little bit of a spike there at the end of last year, and that was when vaccine became available for the 5 to 11-year-olds. And now we've tapered off quite a bit again. Going down to the center left, you'll see some bars showing vaccinated percentage by age. This is all data, by the way, that's available on our COVID dashboard, which is still present on accesskent.com. You'll see that we kind of stair-step up from that 5 to 11-year-old group at 39% of that population being fully vaccinated, up to our older groups, and people 65 and older were in the mid-80 percentile range for those older groups. And then over one more to the left, you'll see vaccinated by sex. The females in Kent County are a little bit more receptive to vaccine than the males are. About 70% of females in Kent County are fully vaccinated to 64.6% of the males. Overall, Kent County is in the top 10 of Michigan counties with our vaccine rate, so we're pretty proud of that. But the real measure of how successful we've been during COVID is the number of people that we've lost, and we sadly have lost, as of last week, 1,376 people to COVID-19. However, our mortality rate has been a lot lower than other places, and it's been a lot lower than what we originally were concerned about. If you remember those early days when we were hearing from China of a mortality rate of 5% or more, we were afraid that we might lose, many thousands of Kent County residents. Thankfully, that was not the case. We do have a mortality rate which is measured the number of people who died versus or compared to 100,000 of population. We have a mortality rate of 208 per 100,000 population here in Kent County. For perspective, the state of Michigan is at 370 per 100,000 of population, and across the U.S. it's at 310 per 100,000 of population. If Kent County were a state, there would only be 8 states that have lower mortality rates than Kent County has. In most of those states are places like Alaska, Utah, Maine that have very low population densities, or places like Hawaii which have lots of open air environments and not a lot of indoor crowding. Our case fatality rate, which is the number or the percentage of diagnosed cases that die, is at 0.8%. Overall in Michigan, it's 1.5%, and across the U.S., it's at 1.2%. And there at the bottom, we have the graphic showing our line of deaths by date from the beginning of the pandemic to date. You see we've had a couple of periods there where our hospitals were really in crisis, and we were hit hard by COVID deaths in late 2020, and then again in late 2021. Right now, we still are losing, sadly, we start losing people to COVID at a pace now of about one every other day. So thankfully, it's a lot lower than it has been, and hopefully we don't see any kind of resurgence like we've seen in the past. I don't expect that we will, but it is, of course, something we're going to watch carefully. Looking ahead at some priorities, some near-term priorities that we have in community clinics and community wellness. Number one right now is communicating the availability of maternal and infant health services. And again, we've heard an awful lot of concern that there's not enough service out there for expecting moms and new babies. And we want people to know that we have quite a bit actually available here at the Kent County Health Department, where we can help moms, babies, and we can get them a higher probability of having a full-term birth and not being low-term or low birth weight, and getting them off to as best of a successful start as possible. Surveillance, of course, is always part of our priority set. COVID-19, yesterday was kind of a big day where we had the first case of monkeypox diagnosed here in Kent County. We also had the first West Nile positive pool of mosquitoes identified in Kent County, which is a little bit earlier than we normally see. Usually that's an August observation. This year it's a little bit earlier. So those kind of things, monkeypox, it is nowhere near the level of population threat as COVID or influenza or some of the other things that we're worried about. But it is, like with West Nile virus, it's something where information is empowering, and if we can provide people with information of what's happening, especially things like that aren't really a surprise to us. We know that West Nile virus is going to come every year. We've known for a while that it was inevitable that we were going to have monkeypox cases here and probably everywhere. But with information, we can really empower people to take control of their risk. We're going to recover, regain, and restore excellence across our programming, and that's what I think you saw in some of those measures, is that we're bouncing back from COVID across the spectrum of our programs. And a lot of programs, we had to reassign people from what they were normally doing into COVID response activities. And then start planning, and we're in the midst of that right now, and we're doing our best to make sure that our strat plan reflects the strategic priorities of this board, and that we're all aligned going forward. And finally, I just want to say thank you on behalf of our department for your support. And I have to include this picture because we love this picture. It's one of our beautiful little Kent County residents getting her vision examination. And again, that's a program that really makes a lot of difference. Identifying those deficiencies early and getting kids to a start where they don't struggle academically or socially as much because they have that support is really important. So I'll stop there, and we can take any questions that you may have.
All right, thank you for the report. Are there questions for Adam? Commissioner Burrow.
All right, thank you, Chair. Adam, thank you very much. I so much appreciate the condensed versions and breaking things apart, because again, 15 minutes, people start to lose me really quickly. So thanks for keeping Kent County healthy. It's a big job, it's an important job, keeping our community, our children, our workforce, and our elderly safe and feeling free. They can move about our community. So like vision and hearing screening. And I'm sure there's programs, I know there's programs, so big population, a lot of folks that may be a little bit more economically challenged. What are we doing for some of our younger people with, whether it's a hearing issue or eyeglasses, what kind of support are they getting in our community? And how can community members that need that support, where can they reach out to?
Yeah, well, vision is one of the resources we're pretty rich in Kent County. So primarily, the initiation, the entrance into the system is through our hearing and vision technicians at the health department. They do the screenings and they identify what children have a visual deficit. Then they are referred, and happily I can say we have two really great resources for people who can't pay. One of those is Cherry Health, and they actually have vision that comes right into the schools. So ophthalmologists and optometrists come into the schools and will fit children with glasses at no cost. There's another program called Vision to Learn, and that program is predominantly in the city of Grand Rapids. It has a little bit in Kentwood and Wyoming as well. And they also will fit children with glasses. So we also do follow-up to make sure if a child has been identified as having a vision deficit, not only do the parents know, but they have the resources they need to get the child whatever follow-up they need.
All right, great. I appreciate that. I think the vision screening's great. I think the first time I found out I needed glasses, I couldn't read the bowling screen up at the bowling alley. I'm like, uh-oh, something's a little wrong here. So it's nice for a young person to be able to clearly see what they're learning up in front of them when all of it is difficult to learn when you can't see what's in front of you, so or hear. So again, I really appreciate the work you do.
All right, Commissioner LeGrand.
I have kind of a string of questions here. But first of all, I served on the board of Cherry Health for many years, and that vision program is amazing. And they also have a great vision program for adults who, might not be able to afford to go the regular route. So that's something everyone should know for their constituents as well. But I have a few questions. One is, our infant mortality rates, are those full-term births, or do we include premature births in those figures?
We do include preterm. It's any live birth.
Okay. And then the children's special health care, is that related? There's a state insurance program called Children's Special Health Care. Is this a branch of that? Is it related?
And I'll let Joanne speak to that.
Yes, every county in the state of Michigan has Children's Special Health Care Services, so it's funded it's supposed to be about 50%. It's not quite there, but about 50% from the state of Michigan. And then we have some matching funds locally. And so it is the same program. It is run out of the state. They have a central database that we put our materials into their database. But it is a state Children's Special Health Care Services. For those of you who are my age or older, you might remember as Crippled Children's. So it's the old Crippled Children's Fund from way back. It began because of the polio epidemic.
Great. And then I have a question about the maternal infant care. How do mothers find that service? How do they get referred?
First of all, the Maternal Infant Health Program is one of 3 home visiting programs that we have. They're evidence-based. We have excellent outcomes to demonstrate that it really does make a difference in the lives of the mom and baby. Most of our referrals at Kent County Health Department come from WIC. So pregnant women tend to know about WIC. They come for their WIC visit, and then as they have their WIC visit, they're offered a referral to our MIHP program. We also get referrals from OB offices, from anyone that comes in contact with pregnant women tend to know that there's a service that will help them. Another huge source of referrals that we have is CPS. So after the baby's born, if there is a concern, part of the CPS plan to support this mom who's vulnerable and at risk for abuse is to refer them to our MIHP.
Okay, wonderful. And just one last question. I promise, last one. The refugee program, great to hear about that. Do we do vaccinations for them? Do they come with vaccinations? Do they have to get them to enter, or how does that work?
We do a vaccine check for them. In most cases, their vaccines have already been arranged through the State Department before they arrived. There are, however, cases where that hasn't happened, and in some cases where there are accelerated conditions, like with the Afghan refugees, that there often are things. And I should also say that I didn't mention Ukraine. during that. And while the resettlement program isn't officially working with Ukrainian refugees, informally they're helping to navigate a number of women and children into families that are already here from Ukraine. And so we are working with them in that same way. And we often see that when there are accelerated processes or where there's unusual things like this, that's when things get missed, and that's where we do pick up a number of vaccines.
Okay, thank you.
Yeah.
All right, Commissioner Hennessy.
Talk about these refugee programs. Can you give us an overview of how you're handling the language difficulties that people have?
Joanne's a fantastic expert on this. She's been working as near and dear to her heart for a long time.
Well, it depends on the language. We have a number of agencies in town that provide interpreter services, and we have contracts with them. The Ukrainian refugees have been particularly challenging because they're new to our community, and we don't have a rich pool of interpreters for the Ukrainian language. But we have been able to find enough people that we can work with them. Interestingly, with the refugees from Afghanistan, many of them were interpreters for our military in Afghanistan prior to coming. So many of them have excellent English, and they sometimes come in with family members that don't speak English, but the head of household does speak English. So we are required and certainly are committed to providing linguistic services in the language that they understand and best communicates with them.
Thank you.
All right, Commissioner Kallman.
Thank you, Chair. So I think we can all be thankful for Dr. London, your whole team's efforts during the pandemic, and just the extraordinary amount of work that went into that. So I think our whole community is thankful for that. I think certainly we've had lots of policy debates and questions and conversations, and I, for one, will continue to advocate for fixing the governance problems in the state public health code. So I do want to address, though, like a specific concern about that work session from last August, where it was certainly the most well-attended work session that I've ever been to. But just about the honesty and transparency of the process. So specifically, I remember in your prepared statements, you had brought some letters from pediatrician groups and and others. One of those was from the Kent ISD, and then later, some weeks after, we found out that what you had referenced there was actually in their letter to you was actually content that you had written and had asked them to put the words imminent danger in there. Like, just from a transparency, honesty of the process, like, why is that okay?
So I did not write the letter from KISD to me, Summer. They had drafted the letter, and they shared the draft with me to make sure that it was expressing their observations and what they wanted to communicate in alignment with what the public health language and the public health code was. So working with community and communicating with partners is always something we're going to do. And working with KSD, working with any other partners, is we're going to try to work with them and communicate with them as best we can, regardless of what the issue at hand is.
Chair, if I could follow up on that question. So just to make sure I'm understanding, so it's my understanding that the specific portion you cited to us in your prepared statement was language that you had written, and prior to the ISD drafting that letter, you did just specifically say to them, use the words imminent danger. Is my understanding incorrect?
To be perfectly honest, I would have to review the correspondence from the time, because I haven't looked at or thought about it in many, many, many months. What I did not do was write their letter. They wrote their letter, they reviewed it as a leadership group, they signed off on it. That's all I can say at this point. But I was not the content creator of their letter.
Thank you.
All right, thank you. Commissioner Skaggs.
Thank you, Dr. London. My question is on a lighter note. You mentioned that West Nile had been discovered. Was that in my backyard again?
I don't know. I'll have to check with the team.
All right, they were there yesterday. I saw them, so they were collecting some samples and have been.
I'm hearing a slight no over my shoulder
Okay.
from my team, so I don't think so. Generally our practice is to inform the property owner where our test was collected from very early, and then we also work with the local unit of government. So in the past, some have decided when they get that notification to apply larvicide to their stone.
Right, that's what we did last year, yeah.
Yeah, and that will knock down the next generation of the Culex mosquitoes. But this year, it's been awful dry.
Yeah.
And that's usually for most of the nuisance mosquitoes, of course, we like, they don't like dry summers, but the Culex mosquito actually likes the dry weather because they tend to more prolifically breed in those small, unmoving bodies of water like a sewer catch basin. When they get flushed out, the mosquitoes go away. But when it sits stagnant, that's why going back to empowering with the information part, like we're going to right now step up our messaging to families about do a walk around the property and look for pop cans in the bushes, the dog dish that has water sitting stagnant in it, the kiddie pool, whatever it is that has stagnant water sitting in it. If it's staying stagnant for a couple weeks, that's going to create the next generation of this particular type of mosquito.
Great. I'll look forward to getting that information.
All right, any other questions or comments? I just have one. In your priorities, it says recover, regain, and restore excellence. What would you say is your department's greatest need to, fix that priority?
Well, I think, to be honest, internally, I think it is rebuilding the culture that we had. And when you've got people who are working remote virtually for long periods of time, we've had a lot of turnover in the past couple of years, a lot of turnover in the last couple of years. And so getting to know the teammates on a first-name basis, reestablishing the interconnectivity between programs and between the staff and the programs. Those are things that mean an awful lot when there is a challenge happening in one neighborhood. And if the team that's working that problem knows who their resources are in other teams within the health department on a first-name basis, things get done a lot more quickly and more at a higher level quality for the people in that neighborhood who we're serving. So it's rebuilding that internal culture, I think, is the number one thing we need to focus on.
All right, thank you. Oh, Commissioner Hennessy.
Your question just prompted one in my mind, and that is, this committee often interviews people for board appointments. I would like to know, how do you use your community advisory board? Is it useful to you? How's it used?
It is, and Commissioner Teal is the chair of our Community Health Advisory Committee. We meet quarterly, and I think it's very useful. At our last meeting, we were able to talk about things like our vaccine messaging and having a back and forth about, what are the messages that are effective and what are things that we need to improve on with our communications to address vaccine hesitancy. We also talk about some community collaborations and how to best partner with others in the community, and even becoming aware of different initiatives that are happening in the community that we might not otherwise know about. So our Community Health Advisory Committee, I would say, is very helpful, and it's very diverse too. We've got people from a number of different professions and educational backgrounds and different regions within the county that are on that group that I think really we have a lively conversation, and we had a great lively conversation last time, and they continue to provide back and forth with me in email and phone calls between the meetings. So I like working with that group a great deal.
Thank you.
All right, any further questions? Seeing none, thank you for your report and all the work that you do within our community. I appreciate it. All right, we have a couple other Health Department items on the agenda. Our next one is from the Health Department. It's adding one medical social worker position to the Health Department for the Children's Special Health Care Services Program.
I apologize for my voice. Has a really bad allergy thing going on. Anyways,
Would you like me to read it?
I'll try it.
Okay.
Recommend to the Board of Commissioners to add one full-time medical social worker position. The CSHCS program enrolls qualifying families and provides support services, care coordination, education, advocacy, and home visits to children who face serious health issues. Without these critical services, the child's quality of life would be greatly diminished. The number of families that qualify for services has increased by 54% in the last 5 years. Enrollment in 2017 was 2,400 families, and that has increased to 3,700 families in 2022. The number of diagnoses that allow a family to qualify for services has expanded during this time, which has contributed to some of the increase. The addition of the medical social worker position will allow the CSHCS program to do outreach in underserved communities who are not adequately represented in the current program enrollment, as well as provide case management services for current families enrolled in the program. The annual cost of salary and benefits for this position is $84,491. The position cost of $14,082 for the 2 months remaining in budget year 2022 will be funded with maternal child health grant dollars that have been unspent due to a vacant position originally budgeted in the grant. For budget year 2023, the position cost of $84,491 will be funded fully by the Maternal Child Health Grant Program. If approved, the position and funding will be included in the Health Department's FY 2023 budget that will be presented for approval later this year. If funding is eliminated or decreased, the positions will be eliminated unless continuation funding is approved pursuant to the fiscal policy on grants, contracts, and donations.
Thanks, Al. Is there a motion? Moved
Support.
and supported. Moved by Commissioner Teal, supported by Commissioner Burrow. All right, any questions or comments on this particular item? Commissioner Kallman.
I'd just like to comment that I'm strongly in support of this. You know, the need is clear in terms of the increasing reliance on children's special health care in our county. And as a dad of a couple of little guys with a lot of medical needs, we're kind of in the communities that depend on this program, and it's so important for those disabled or medically challenged kids in our community.
Thank you. Any other comments on this item? Commissioner LeGrand.
Yeah, I just have a question. It says that the position cost in budget year 2023 will be funded fully by the Maternal Child Health Grant Program. Is that a state grant? Where's that money coming from?
Yeah.
Yeah, it's actually federal funds that are passed through MDHHS, and then we're a subrecipient of those funds.
Okay, wonderful. Thank you.
All right, any other questions or comments? Seeing none, all those in favor, please say aye.
Aye.
All those opposed, please say nay. Motion passes. Our next item on the agenda, I'm actually going to have Linda Howell read. So
All
you
right.
have to go through it, but
Okay.
it comes from the Health Department to add one medical social worker position to the Health Department for the Nurse Family Partnership Program.
Action requested. Recommend to the Board of Commissioners to add one full-time medical social worker position. The NFP program is an evidence-based national nurse home visiting program that serves the highest-risk, first-time, low-income moms in Kent County and addresses the disparities we see in babies born into disadvantaged circumstances. The program has been successful in helping mothers break the chain of poverty and raise healthy, happy children. Enrollment must occur before 29 weeks of pregnancy, and the program continues until the child turns 2 years old. The Health Department currently has 6 public health nurses who carry a caseload of approximately 25 to 30 clients each. The addition of a medical social worker position would be a full-time master's prepared mental health professional with the Infant Mental Health Level 3 certification. Mental health conditions are common in the perinatal period. 15 to 20% of women develop symptoms during this period, and women of color and those who are under-resourced have even higher incidence of perinatal mental health conditions. The addition of a medical social worker will provide clients easier access to care, interventions that are needed, and clients are more likely to accept services if offered within the NFP program that the client is engaged in. The annual cost of salary and benefits for this position is $84,491. The position cost of $14,082 for 2 months remaining in budget year 2022 will be funded with NFP grant dollars that have been unspent due to vacant positions originally budgeted in the grant. For budget year 2023, the position cost of $84,491 will be fully funded by $126,141 of new NFP funds awarded to the Health Department through the MDHHS Comprehensive Agreement. If approved, the position and funding will be included in the Health Department's fiscal year 2023 budget that will be presented for approval later this year. If funding is eliminated or decreased, the positions will be eliminated unless continuation funding is approved pursuant to the fiscal policy on grants, contracts, and donations.
Thanks, Linda. Is there a motion?
So moved.
Moved by Commissioner Burrow. Is there support? Support by Commissioner Hennessy. All right. Any questions or comments on the item? Commissioner Hennessy.
Thank you. I found the one phrase here kind of curious is to, enrollment must occur before 29 weeks of pregnancy. I really support this program where you hit the first-time moms, you hit them over a sustained period of time. But oftentimes, I'm thinking just like, you don't know until you've had the baby that that you really need this. So I was curious about the 29 weeks of pregnancy statement.
Yeah, absolutely. It's kind of a shock when you bring a brand-new baby home for the first time. And that would be a time that many moms reach out for services. When they reach out for services or are referred to us at that point, they would then go into MIHP. Because with Nurse Family Partnership, one of its main objectives is full-term healthy babies. And if the baby's already born, you can't impact that. So the research around NFP tells us that the earlier they begin in pregnancy, the better the outcomes. So the program model itself requires that enrollment happen before the 29th week to give those last 10 weeks of preparation to make sure that that baby's coming home to a healthy home.
And again, as you said earlier in your report, you get the doctors, the professionals that you deal with are all familiar and know how to refer?
They do, yep.
So that's not a problem.
It's something that we have to keep always in the forefront because there's a lot of turnover in the medical community. Just because people knew about it last year doesn't mean the staff knows about it this year. So we're constantly doing outreach to make sure that the community is aware of this resource.
Thank you.
Commissioner LeGrand.
Commissioner Hennessy beat me to the punch about the 29 weeks. Is that true for, we talked about someone who came home with a baby, but weeks 30 through 40, same story, you get referred to a different program?
Weeks 30 through 40, they would be referred to the maternal infant health program, yes.
Okay, all right, thank you.
Mm-hmm.
All right, Commissioner Skaggs.
Thank you, Chair. And the person that we would look for would have, cultural competency in the communities that they would serve, I assume.
Absolutely. In fact, Nurse Family Partnership is one of the programs that invests the most in training to make sure that that the home visitors are just really great at relationship building, at understanding the culture, and working with people within the context of where they are.
Right, and they're serving just 25 to 30 clients each, so that's some pretty hands-on.
It is.
support.
It is the lowest visit to home visitor ratio of all of our programs because it's the most intense. So they actually often get 2 visits a month, and they also, it depends on the desire of the mother, but 2 visits a month with sometimes check-ins in between, especially right before the baby's born and right after the baby's born. That nurse home visitor is in the home, or in this case it would be a social worker, is in the home as that mom's bringing home a new baby.
Thank you.
Thank you. Any other questions or comments? All right, seeing none, all those in favor, please say aye.
Aye.
All those opposed, please say nay. Motion passes. Our next item on the agenda is miscellaneous. Is there any commissioner miscellaneous? Nobody? I just have a brief one. Following our meeting, in a couple minutes, we'll have the branding update in room 311. So head over there for the update. It probably won't take too much of your time today. Lori's shaking her head, so she's in agreement. Is there any other commissioner miscellaneous? All right, seeing none, I call to adjourn, and our next meeting will be August 9 at 8:30 a.m. We'll see you next door, and we'll see you next month.